Let's do the roll call first and make sure that we have everyone here. Let's just go around and just call off your name, please. Adrian.
Adrian Casillas.
Mary Ann Fletcher.
Jordan Dimitrikov.
Eileen Halderman.
Beth Collins Sharp from AHRQ.
Deborah Willis-Fillinger from HRSA.
Terry Michelle from FDA.
Ermias Balai from CDC.
Nancy Lee.
Marty Bond, Office on Women's Health.
Susan Meyer, NIH.
Elaine Perry, CMS.
Dane Cook.
Susan Levine.
Ann Vincent.
Okay. Jacqueline Rose.
Steve Kravchik.
Thanks, and remember everyone, use this because Deborah back there is taking wonderful minutes for us, and it's also being recorded for posterity and for current live video streaming. And we have an open phone line for people to call in as well. So we're definitely wired to the outside world. I hope that the live video streaming and the audio hookup worked yesterday. I think it's fabulous that we have this opportunity. I do want to just go on the record as saying, given the budgetary situation in Washington, we are very happy to have this opportunity. We don't know how long we'll have it. We couldn't afford the contractor that we had in the past, and this one is a wonderful in-house opportunity for us, and we just hope it keeps going. But we're doing the best we can with that, given our funding. So I think it's a good time. Maybe before we do that, are there any questions or other comments that the committee wants to raise before we begin with the agency updates? Yeah, Steve.
I'd like to resurrect the motion that we had yesterday and modify it slightly on the use of the primer.
Can we? I think that would. Can we do that this afternoon during the discussion, or would you? Or do you want to do it now?
Pleasure of the group.
Yeah.
You want to do it now?
Steve, I would wait because I think there might be a fair amount of discussion and we want to hold up the speakers.
Fair enough.
Yeah. Okay. Thank you. I was more thinking of housekeeping and immediate little things here at the moment. Okay. Thank you. So we're going to start with our agency updates, and let's start with Beth Collins Sharp from AHRQ. ARP and AHRQ. Sharp and ARP.
AHRQ. We're like the AHRQ. No, it's AHRQ. Good morning. I'm Beth Collins Sharp from the Agency for Healthcare Research and Quality. It will be a relatively short report out this morning. There's not a lot new to tell you from last time, and I anticipate that I'll have more to tell you in the subsequent discussion on funding opportunities. But for the benefit of the new members and folks who haven't heard this before, the Agency for Healthcare Research and Quality, or AHRQ, is one of the smallest agencies, if not the smallest agency, in HHS. We are a research agency. We're not a regulatory agency, for example. And we focus on healthcare research, not health research. We're the Agency for Healthcare Research and Quality. As such, then, our portfolios of research don't focus on specific disease entities, but rather on health services research, and our portfolios are things like health information technology, patient-centered outcomes research, patient safety, primary care and prevention, for example, value and innovations. I think that's all of them. So it's a different framework than perhaps you're used to. We have a small grants program, which is an investigator initiated, and we'll talk a little bit more about that in a moment. And we also have a number of contracts, one of which is the Medical Expenditure Panel Survey, which is an annual survey of, as its name says, medical expenditures. It's a generalized survey, but it's well respected and used quite a bit by Congress and other stakeholders. And just prior to last meeting, there was a statistical brief put out on pain conditions, healthcare use and expenditures for pain conditions among women. And this was a pooling of data around a number of pain conditions, including chronic fatigue syndrome. Some of the others were fibromyalgia, TMJ, vulvodynia, endometriosis. So it was a whole gamut of conditions. Subsequent to that, and after the last meeting, I talked with the investigator who did this brief and the statistician and asked if we could pull out the chronic fatigue syndrome patients to look at those individually. And the number was just too few. So then we tried to be creative and pool data across a number of years. And she went back, I've forgotten, frankly, how many years. I'm going to say 10, a lot of years. And we still were not able to pool enough data to do any meaningful or helpful analysis. So that was disappointing, to say the least. I was pretty excited that we would be able to do that, but it practically just was not possible. I give you this example not to add to your frustration, but to show that this is one of the challenges that we have. And I know we all know this, but I just wanted to give this real-life example from our perspective of how it's frustrating on this end as well, and that there are attempts to do these sorts of analyses. So I think with that, then I will stop, because I think the next conversation will be a place where we can have more information from what AHRQ has.
Thank you very much, Beth. So our next speaker is Susan Meyer from NIH. Susan.
Thank you. My name is Susan Meyer, and I will be giving the update from the National Institutes of Health. The National Institutes of Health, as I'm sure most of you know, but for those of you who don't, there's a brief description on the screen. The National Institutes of Health turns research discovery into health and applications. NIH is made up of 27 institutes and centers. Each has a specific research agenda. Sometimes it focuses on a specific disease. Other times it'll focus on a particular function, such as review. The leadership plays a very active role in shaping the research agendas for the entire NIH and with stakeholder input. So how do we get this work done? The Trans-NIH ME CFS Working Group is the vehicle that takes care of research and activities related to ME CSF across NIH. We are located in the Office of Research on Women's Health. This is in the Division of Program Coordination, Planning, and Strategic Initiatives within the Office of the Director at NIH. So we are not within an institute, we are within the Office of the Director. Our membership on the working group includes representatives from 16 NIH institutes and centers and offices. And I'm pleased to say that we've recruited recently, we have recruited membership from the new Center for Advancement in Translational Sciences, or the NCATS. I'm the chair of the Trans-NIH ME CFS Working Group, and I serve as NIH ex officio on the CFSAC. Our duties and obligations are wide-ranging. We look at cross-cutting areas of research across ME CFS, and we try to identify and match resources that are needed by investigators with opportunities that are available at NIH and across other agencies. We disseminate information about the research findings on a public website through a listserv, and we communicate new and ongoing research activities to the NIH leadership directly and to HHS leadership through this committee and also through other calls and other activities that we do. We have monthly meetings. We update the website. We provide information to potential applicants. And we seek out new investigators to the field. They may not be doing research on ME CFS, but they might be doing something in a very similar field or a very similar area. We try and leverage their expertise in those areas to bring that into the field to try and advance research. And we also do a lot of thinking and a lot of discussion about developing plans for moving the field forward. We have several accomplishments. I might hazard a guess that you might not think these are very exciting, but the fact that I've only been in this position since January, I think that we've done quite a bit, and I hope to do a whole lot more. We've developed a dedicated internal website for communication, document review, and sharing ideas across all of the institutes and centers. We've hosted guest speakers who have expertise in different areas that we're interested in. For example, an intramural researcher from the Nursing Institute came and talked about his research on fatigue and looking at the genomic aspect of identifying various subgroups of fatigued individuals in cancer patients, and his next project will be in CFS patients. We also had a speaker come and talk about strategic planning and how to develop and evaluate and to track progress on strategic planning, because that again is an important aspect of moving things forward, is developing a plan and moving it forward and evaluating how well that plan is working. We've developed those to priorities from the State of the Knowledge workshop, and our next action item for us is to turn those recommendations into actionable items. We're using an action matrix and trying to identify the short-term, low-cost things that we can do and moving some of the priorities or moving some of the recommendations into the long-term, high-cost. Depends on how we can implement those, but this is one way to move this forward in thinking, is how to get all of the recommendations into an action matrix and be able to implement them. And late breaking news that wasn't available when I made up the slides was that the Center for Scientific Review has agreed to change the name of the review panel that's dedicated to reviewing the applications on CFS to ME-CFS, replacing the CFS. So it will be, I don't know its complete and full name, it has some codes to it, but it will have ME-CFS in the name. Well, we hope to move forward, obviously. We do that through several different activities. One is we collaborate with other trans-NIH working groups. For example, we're working with the Trans-NIH Chronic Overlapping Pain Conditions Working Group. This is a relatively new working group, and this brings together individuals across NIH with an interest in chronic overlapping pain conditions. They are holding a conference in August. It will be open to the public. And once the information is available about the conference and how to register, I will put it out on a listserv. We're also working with the NIH Pain Consortium, and recently we awarded 11 contracts, and this is to develop and disseminate educational materials for health professionals on all aspects of pain, pain treatment, and pain management. There are many of these centers, when you look at their plans for education materials, involve education for nursing, education for pharmacy, education for physicians, education for dental practitioners. So there's a wide range of activities that are ongoing in these centers. We want to make sure that we can, as I said before, leverage the resources and expertise from others to advance our mission. We have a couple things that we'd like to do, and you can read these on the screen, but we want to develop a means for documenting and storing consistent, well-defined, reliable research outcomes using current tools and resources. And we'd also like to identify methods to engage multiple ME-CFS researchers to collaborate on focused projects with defined outcomes. There will be, once this presentation is posted, there will be information on, in the presentation on funding that's available or that has been expended by NIH on ME-CFS right now, and for fiscal year 11 at $6.3 million. examples of funded projects I'm listing here on the screen. And the reason that I'm listing these particular ones, these are not my favorites, they're not the only ones, but the reason I'm listing them is because I wanted to demonstrate that we engage with researchers in a variety of activities. So, for example, if you look at the first one, efficacy of home-based self-management for chronic fatigue, this is, in brackets, you'll see the R42. The R42 mechanism is a small business technology transfer grant. All right, this is, supports in-depth development of research and development ideas. And its feasibility has been established, but they'll result in commercial products, things that people can use. We support, if you notice the second one from the bottom, it's an F30. F30 is a mechanism. This is an individual predoctoral fellowship for MD, PhD candidates. It's used to train future physician researchers. So we're training the next generation of researchers, and if they're doing research projects on ME/CFS, then it's very likely that they will continue in this field, and we think that this is an important way to go. What can you do? What can I do? Clinical research relies on human subjects. Everyone can make a difference. I'm sure most of you know about the clinicaltrials.gov website, where you can search for clinical trials in any disease area. You can search by geographical location. I looked up what we had, and there are 37 studies using the search term chronic fatigue syndrome that are currently open and recruiting, or either open and recruiting. There are examples of interventions that are being tested in trials. I refer to them as drug and non-drug, even though I think my FDA colleagues might disagree with that classification, but for a biologist, that works for me. So how does the research get funded? And I think we'll probably talk about this a little bit more, but I just wanted to give you a flavor of what happens. NIH funds things through grants or through contracts. There are investigator-initiated applications, and there are solicited or targeted applications. 70% of the applications that NIH receives are investigator-initiated. And I just want to stress that a solicited or a targeted application or targeted request for applications, even though that goes out and there's a set aside of funds attached to it, that does not mean it will be awarded. All applications that come into NIH have to be reviewed, and it's a competition. It's a competition for the best science. So here's an example of investigator-initiated examples of parent announcements. These are announcements that investigators can use to submit their application, and these are the application notices for the investigator-initiated ones. As of June 6th, these are solicited or very targeted funding opportunities that were available. Note that there are PAs in here, that's a program announcement, versus an RFA, which is a request for applications. If you look for targeted funding opportunities for ME/CFS, you will see our very favorites up there at the top. Those are PARs, that's a program announcement with a specific review panel attached to it. Well, we can go beyond ME/CFS and look at other aspects, perhaps, of the syndrome itself. So if you look for funding opportunities on fatigue, these are the ones that are available right now. This is a branching out. This is looking for opportunity beyond the letters ME/CFS. And I think that this is important in an era of flat budgets, limited funds, limited people resources. This is what we're going to have to do as an approach to get the maximum amount of work and research done with limited funds. Again, branching out again into pain. Just look under what's funding opportunities available for pain. Again, a way to branch out. I want to give you some examples of what else is available. What else can we do? Here's one example. The National Center for Advancing Translational Sciences, their mission is to catalyze the generation of innovative methods and technologies that enhance the development, testing, and implementation of diagnostics and therapeutics across a wide range of human diseases and conditions. This is the newest center to be added to NIH. It has very specific program announcement that's coming out. And they have a division that deals with drug rescue and repurposing. And the reason I brought this up is that the drug rescue and repurposing is it's a several-pronged approach. It's to take drugs that have been used for other disorders and diseases in the past, and it's to take those and see if they're applicable to different diseases, different disease categories. The drug rescue program is designed to bring new chemicals or chemicals that have been abandoned by drug development through companies. If they've been abandoned, they have not been used for the purpose or not going to work for the purpose that they were intended. And the NIH has gone into an agreement with Pfizer, with Lilly, and with Roche to get that they will agree with investigators to repurpose those or to rescue those drugs, and they will allow them to be used in clinical trials after application. I think this is a fantastic opportunity. I'm not sure what will come of it, but I think it is an opportunity that's worth pursuing. The second thing that I wanted to highlight with the NCATS Institute is the Clinical and Translational Science Awards. These are very large awards. They provide critical infrastructure and support needed to advance clinical translational science. There are CTSAs across the country, and they are always looking for partners. They're always looking to bring in new people. And I think that if the infrastructure is what's needed, that by individual investigators who want to work on ME/CFS, I think this is an opportunity for them to be brought into that fold and have access to those resources that are available and already supported. Let me give you a second example. Maybe. There it is. The NIH Clinical Center. This is the nation's largest hospital devoted entirely to clinical research. They have a very broad mission statement, and it includes investigating the pathogenesis of disease, developing state-of-the-art diagnostic, preventative, and therapeutic interventions, conducting first-in-human clinical trials with an emphasis on rare diseases and diseases of high public impact. About 1,000 clinical research studies are underway at the clinical center, and in fact what I did was I did a search somewhere. I did a search, and some of the results are listed here. So I looked up in the clinical center protocols related to chronic fatigue syndrome, and these are the ones that are active currently. Okay, and there are obviously not a lot of them, not as many as in clinicaltrials.gov, but there are opportunities. There are opportunities for the clinical center to collaborate. It's a new model. It's just been adopted by NIH, is to open up the clinical center to all researchers and have them come in with a defined protocol and to perform research. I might also mention the Undiagnosed Disease Program. I know that has been a focus of some individuals for opportunity. It's available. It's still there. It takes an application to get in, but it is available. So I've talked about opportunities, and I think we're going to talk about opportunities shortly after this. I looked up the definition of opportunity, and you can see that here are some of the definitions, a lot of them from Wikipedia, but I did look up Merriam-Webster, just to be sure. So they're a good chance for advancement or progress, a situation or condition favorable for attainment of a goal, and this is my favorite, a prospect for success. And this is what NIH is looking for, is the opportunity to work together for a prospect for success. If you have questions, if you want to chat, if you need more information, you're welcome to contact me. I have business cards with me, and I am glad to talk to you. And here's a list of all of the websites that I've mentioned. I also do have some handouts if you need a paper copy. I've got some of these with all of these websites listed. Thank you very much for your time, and that's it for me.
Thank you. That's terrific. Should we go? Should we have questions now, or go to the other two? Let's do the other two. Yeah, I can't remember what we had decided. So the next person is Deborah.
Good morning. So I'm Deborah Willis-Fillinger. I'm with HRSA, the Health Resources and Services Administration. And HRSA is the HHS agency that focuses on access to healthcare services. We focus on services to vulnerable and underserved populations. Most of the programs that we fund are not disease-specific, except for HIV/AIDS. We primarily focus on support for services and for infrastructure to healthcare services. So, for example, we have four major. Well, I shouldn't say that. We have 5 bureaus. We have a Bureau of Health Professions that focuses on health professions education and training. We have a bureau that focuses on HIV/AIDS education, training, resources, healthcare services. A maternal and child health bureau that focuses on support for women, children, and families. And we have another bureau that focuses on primary healthcare services, infrastructure, and direct care services. So, for example, the Community Health Center program that was mentioned, that has been mentioned in the past, some of the grantees, I think about 16 of the community health centers participated in the Project ECHO, which was mentioned yesterday, that studied that program that helped providers and communities learn how to adequately serve their patients with hepatitis C, and that program has expanded to include HIV and a number of other diseases as well. So HRSA, in terms of things that we've specifically done since the last meeting, we were very excited to see the CME that was developed by CDC, and the agency has begun distributing that CME to the healthcare professionals that are associated with our programs. HRSA has a number of listservs, newsletters, and other means for communicating with its grantees and with those healthcare providers that provide direct care services. And that CME, along with an explanation for what chronic fatigue is being distributed throughout that network. So just to give you an example, the Community Health Center network currently serves approximately somewhere between 16 and 20 million patients. It varies day to day depending on who you're talking to and what number you're counting, but that's a lot of those are a lot of people, and so it's very important for us to get into the hands of those providers that care for those patients information about the CME. So thank you for that, CDC. Another example would be a program that we call Family to Families. F2F is what we call it, but it's I've mentioned it before in previous meetings. I think it's in our minutes. But the Family to Family networks there are 51 that have been recently funded across the country. They actually have been in existence since 2005, but most recently, about 4.9 million was funded about 51 centers, and those exist in every state across the country and territory as well. So those networks are centers that provide information to families that help them make health care decisions that are right for their children. There are, as I mentioned, 51 centers, and they're staffed by trained family leaders who have children with special health care needs. And they provide support to families to help them navigate both the federal, state, and local public and private healthcare infrastructure systems, with a focus on advocacy and helping those families get the services that they need. Interestingly, as I listened to the presentation yesterday from the Department of Education about the TA Alliance technical assistance programs, I sent a quick email to my colleague who runs the program, the Family to Family program, and asked if any of those grantees might be the same, and she said absolutely yes. So some of the same entities that get funded by the Department of Education to provide technical assistance regarding schools and school access, those entities also get support from the Family to Family programs at HRSA. So I thought that was exciting, especially since I know that all of those organizations also got the CME and the explanation from HRSA a few days, at least maybe a few weeks ago. So that's really it for me right now as far as HRSA and what we've done since the last meeting, and we look forward to the rest of the discussion. Thank you.
Deborah, thanks very much. And our representative ex officio from CMS, Elaine Perry.
Thank you. Good morning, everybody. Elaine Perry, and I'm with CMS, as Nancy said, and I'd just like to first welcome the new members, and I look forward to working with you, and also just thank the members of the public who are here, who traveled to this meeting and who made the effort to testify. I really appreciate your work with that. I don't have an overhead, but I did pass out just a list of websites because some of them are really long, and I thought it would be hard for people to try to write down, and that will go in the record so that members of the public can see that list of websites as well. I'll tell you a little bit about our agency. The Centers for Medicare and Medicaid Services, or CMS, administers the Medicare program, which most people are familiar with, provides health care coverage for the elderly and persons with disabilities. And we also administer the federal portions of Medicaid and the Children's Health Insurance Program, both of which are joint state-federal programs. So overall, about 100 million Americans receive health insurance through one of our programs. People with CFS may be eligible for Medicare or Medicaid based on disability, based on their age, because they're low income, or some combination. For example, if an individual with CFS becomes entitled to Social Security disability benefits because of their disability, after a 24-month waiting period, they would then become eligible for Medicare. If they became entitled to SSI, which is for people with limited income due to disability, then in most cases they would become entitled to Medicaid through that. But we could also cover people with CFS who are on Medicare because they're elderly, or people who are on Medicaid because they're low income. They may not necessarily be getting disability benefits, but they may just be low income and qualify for Medicaid from other ways. We also, in addition to those programs that we run, with the passage of the Affordable Care Act, we gained a few additional functions. One is that the Affordable Care Act created the CMS Innovation Center, which I've talked about quite a bit, we've discussed here. And the Innovation Center was charged with testing and developing new models of healthcare service delivery and payment. And I won't talk any more about that now, because during the session on funding opportunities, I'll discuss that Innovation Center a little more. Another major function that we gained with the passage of the Affordable Care Act are functions implementing a number of portions of that law that deal with the private health insurance market and the expansion of health insurance options. So these include working with the states to develop the new health insurance exchanges, which will be up in 2014, overseeing new consumer protections in the private health insurance market, and providing consumers with better access to information about their health insurance options and their rights and consumer protections. At the last meeting, one of the things that we discussed, that the committee was discussing, were concerns that had been raised by members of the public with CFS about having coverage denials, about having health care claims denied for services and treatments related to CFS. And this was discussed, and I remember Nancy Lee looked over at me and asked if there was any role that CMS could play in addressing some of these. So I looked into that, and I just wanted to report back to you what I learned, which is basically that some of the new protections and programs under the ACA could potentially be helpful. So I want to tell you about what some of those are. First, I want to mention a website called healthcare.gov. I've mentioned this in the past. It's listed on this sheet, but it's a pretty easy one. It's just healthcare, one word, .gov. And this is a website that was created to provide all Americans with information about insurance options and just really improve transparency and information and the ability of consumers to make informed choices about their health insurance. So it's very, very accessible. It's I think, a great website. Some people are nodding out there. That's good. It has nice search functions where you can go in and search state by state and search for the different health insurance options that might be available to you, and you can enter different characteristics about yourself. So if you're low income, if you have a disability, and it'll bring up different options that you can explore and how to go about doing that. So it's a really nice website. Another thing is that it has very detailed explanations, but also very accessible, plain English explanations of the new consumer protections under the healthcare law. And all the information I'm going to give you and much, much more are on that website. So I really would refer you to that to get the details. And there's information about, on a state-by-state basis. So it's far more detailed than I can give you. But one of the important consumer protections that I think would be of interest to this group are that the ACA created some new appeal rights regarding claims denials. The new rules apply to plans that are created after healthcare plans that are created after March 23rd, 2010, which was when the ACA became law. And I just want to emphasize too, because sometimes there's some confusion, these appeal rights apply to health insurance plans, not to private disability insurance plans. So I just want to make that distinction. The rights include standards on how plans must handle internal appeals, and they also provide, very importantly, the right to external review by an independent review organization. So you would go through an appeal process within your plan, but then if that wasn't resolved to your satisfaction, you would have the right to go to an external body that had no financial ties to the plan for an external review. Now, this does exclude what are referred to as grandfathered plans, which are health plans that were in existence before the law. And it gets a little complicated because if plans change, there's sort of, how much can a plan change and still be the same plan? There's a question of that. So if a plan was in existence, but it changes significantly, it may no longer be considered the same plan, and it may lose its grandfathered status. So again, I'll refer you to the website for more details about that. But another requirement of the ACA is that your plan give you information about whether it is a grandfathered plan or not. So you'll have that information. Another program that I think could be really helpful is a program called, these are state-level programs called Consumer Assistance Programs, or CAPS. And we fund these programs through grants, and they provide a variety of services to consumers. They can help you find healthcare coverage. They can help you file an appeal against your health plan. They can educate consumers generally on their rights. They're also required to track complaints that are made. So a variety of functions. They can be state agencies or they can be local nonprofits that are contracted by a state. They're currently not in every state, but the Secretary recently did announce a new round of funding for CAPS, so hopefully there will be more. Again, you can go to healthcare.gov and search on your state to see if there is a consumer assistance program and how to contact that. The website also lists other options. If there is not a consumer assistance program in your state, there are other options about where you can go to get help. So next steps, we really are interested in feedback as we move forward. We're in a period of transition with implementing the new healthcare law, and we really would like feedback on how these new protections are working for consumers, and particularly how the appeal rights are working for consumers. We don't have an official structure right now for compiling, complaints that consumers bring at a federal level. But I wanted to just make the offer if this body, CFSAC, or if any of the advocacy groups out there are interested in compiling complaints, concerns that are raised by people with CFS about claims denials. We'd be very, very happy to get that information just on a going forward basis over the next several years. So, I would ask you all to refer people or people in your organizations to the healthcare.website, to their consumer assistance programs, encourage them to file appeals if they have denials, to get help if they need it, and and hopefully, that will work for people, and to the extent that it doesn't, if anyone out there would like to take it on to compile a record of what's going on so that we can begin to see, are there patterns, are there concerns, and are there places where there are gaps that need to be filled. That would be extremely helpful. Also, of course, we make decisions, our agency makes decisions about Medicare coverage, and if there are issues with Medicare coverage for people with CFS, treatments that Medicare does not cover, or situations where people are not getting claims approved. Certainly, I would love to hear about that. Can't obviously make any promises about changes. We obviously have the processes that we follow regarding making coverage decisions, but I definitely would like to hear if there are concerns, and we'll look into that. So just one more thing I wanted to mention before I close. We also recently announced a data initiative. CMS has huge amounts of claims data from Medicare and to some extent Medicaid, although that's more complicated because it's a state, a federal joint program. But this claims information is potentially a very valuable information source for researchers. And we are really working now on making development and management and dissemination of that information a core function of our agency. So, we really see it now as going beyond the record keeping for claims and becoming really a national resource for improving healthcare quality and for researchers to look into all kinds of things. So I wanted to make people aware of that, and also our ex officios. And there's more information on a very, very long web address that is on the handout I gave you. And I would refer you to that. I can't say that I know a lot about how our data systems work, so I probably won't be very good at answering questions, but please do go to that website. There's a lot of information about how you can get access to data if you want to do that. And if you still have questions, then please, let me know, and I'll do my best to get those answered. So I just wanted to say, also extend the invitation to everyone. Very happy to, my door's open if you have questions, concerns, anything you want to talk about. So thank you very much.
Thanks, Elaine. That's great. And your presentation about the Affordable Care Act reminds me that that's one of my big parts of my day job, is to work as part of this administration and pushing out the good news about the Affordable Care Act. And so, while I probably don't know as much about it as Elaine, because it is a very complicated 800-page bill legislation, I wanted to say a couple of other real opportunities that are not specific for chronic fatigue syndrome patients and their families, but something that's really a good news is that in 2014, and Elaine, correct me if I'm wrong, Medicaid eligibility is going to expand greatly. And right now, Medicaid eligibility is determined state by state, and in many states it's really for mothers and their children, and now it is going to be much greater, and income requirements they're going to be the same in every state, so Medicaid eligibility has to be the same in every state, and many more people are going to be eligible. These are going to be low-income, uninsured people, and so that's going to be an opportunity for people with CFS who are having trouble getting insurance. That's in 2014. Have I made any mistake?
The one thing I would correct, Nancy,
yes,
is
please.
Right now Medicaid is available in every state also to the elderly and people with disabilities who have been determined to have a disability, but only to, and also to the mothers and families, but only to people in certain categories. And what the change is that there'll be a new basically coverage category where you just need to qualify based on your income. You don't have to have any other specific characteristics.
Right. So that's very, and the point is it's expanding a lot. Another thing, and I think we've talked about this a little bit in the past, is the pre-existing condition insurance program. That is a bridge program. It's not going to be around after 2014 because the pre-existing condition problems that insurance companies have had before those are not going to be allowed anymore. But in the meantime, it is an opportunity for people to pay for health insurance, but at reasonable costs, and not to be denied because they have a pre-existing condition. And the third is that for people who have to buy their own individual plans, because they don't have employer-sponsored plans, there's going to, if you're at 400% of poverty or less, your income is at 400% of poverty or less, there are going to be ways to get partial help with those premiums. So that's another important thing that I think is something that would be applied to people with chronic fatigue syndrome. Anything else that I got that one right?
Yes.
Yes, good, thank you. Yes, Eileen.
The last thing that you mentioned, is that in effect now, or that will take effect?
No, that's in 2014.
2014, okay, thank you.
So we all, there's some, we're just hoping that this all goes forward. So let's open up, I really appreciate the information from all four of our ex officios from this morning. So if there are any questions or comments from our panelists, now Susan.
Hi, thank you for a great presentation, all of you. I had a question for Elaine and then one for Susan, please. What are some of the downside of the Affordable Care Act? Is it that providers are going to be paid 30% less? I think, correct me if I'm wrong, as of 2013, January 2013. And how will that affect deniability of claims? In other words, if let's say a chronic fatigue patient goes for a tilt table test or another procedure, the providers will get paid. If this, I believe that's true.
I have not. Are you talking about under Medicare or?
Yeah, under Medicare. I understand that as of next year, providers are going to. That's one of the sort of offsets of providing affordable health care to everyone. That the providers will then get paid less.
No, I don't believe that's
I
correct.
mean, we can check into that, but Susan, there is a lot of misinformation that goes out about this act because it has political. And I'm not saying what you're saying is wrong, but
it depends on which administration comes into office too. I think
that's right.
But I think there's some, it's in the New York Times. But anyway, that the way that the government is able to pay, enforce the Affordable Care Act is that therefore the money has got to come from somewhere so that well, I'm just saying that if providers are going to get paid less, will the appeal of the denial process be affected? Well, you're saying that you don't know if that's going to be.
I'm wondering if what you might be referring to is the what people refer to as the doc fix, which is something that's not related to the Affordable Care Act at all. There was legislation passed a number of years ago that changed reimbursement rates to physicians on Medicare, and it turned out to the formula worked out in such a way that payments were lower than a lot of people were comfortable with, and every year Congress has acted on a year-by-year basis to basically change it for that year, but that year only, so they haven't made a permanent change. So
I mean, I think there's something
that might be what you're referring to, but that's not at all related to the Affordable Care Act.
Okay, all right, yeah. Well, I think there's some, again, depending on which administration we get, that might affect payment to physicians and to other
we
providers.
can certainly look into, Elaine and I.
Sure.
I mean, this is both of our day jobs, I think.
Okay. I haven't heard of anything like that.
Yeah, I haven't either. I mean, Beth was nodding over here. Do you?
No, I'm thinking it was the dog fix.
Right.
Okay.
And that gets play every year.
Yeah,
Okay.
yeah.
That we hear about that every year.
What has tended to happen is near the end of the year, it gets fixed for one more year.
Okay, all right.
By but that's up to Congress.
Okay, and then I just had one question for Susan. What mechanism do you use to reach out to other doctors that may not have identified themselves as necessarily being interested in CFS, but you think as an agency that they might be?
You mean reaching out to other physicians or
Other-
reaching out to physician researchers?
Either one, either practicing physicians or, say, rheumatologists, I imagine, or those kinds of specialties.
Sure. So part of the great part of the working group is that there's representation from many of the institutes and centers. And so the experts, those are experts in their area. So, from the National Institute of Allergy and Infectious Diseases and National Institute of Neurological Disorders and Stroke. So there are many people who are in program officers and review people and individuals who are expertise in a specific area. And what we do is as a group, we decide to reach out to those people through going to conferences, meetings. Anytime a person is at a meeting as a government official and is talking to potential grantees or talking to researchers, they will encourage them to apply for funding opportunities, or if they see someone who has a specific technique or a methodology or approach that might be unique and that might facilitate that research, or that's how we reach out to them. Reaching out to physicians themselves through physician groups, we have not done that yet.
Sorry, Dane.
That's okay. My question is for Susan as well. First, investigators, when they're preparing their grants, will oftentimes contact a program officer to help with the development of the question being asked and to make it more appealing to a particular institute. Because CFS doesn't have a true institute home, and you're in the Office of Women's Health or in the director's office, or at least the working group is, would the working group be able to offer that sort of assistance to the investigators, or should they still be going to program officers?
So investigators can contact program officials at any institute and center for information or for technical assistance in applying for a grant. You're right. There's no institute for ME/CFS. However, ME/CFS is a very complex illness. And I think, as I said before, the complexity of the illness really lends itself to a trans NIH perspective. And so if an investigator has questions or has perhaps is trying to find out where best their particular application should be sent, or should be supported by, they may already be coming from a specific approach. So an investigator who is looking at some aspects of care and caregiving might go to nursing. Someone who has they come from an approach where they believe that there's a neurological aspect to it, might go to the Institute of Neurological Disorders and Stroke. But remember, the applications that are received that have ME/CFS in the title or anywhere in its content or in its research plan will be going to a specific review panel. Now, the review panel, once the reviews are finished, or before the reviews are done, but after the reviews are finished and things are ready to be funded if they score well, they will be picked up by a specific institute or center at that point for funding. And then the Office of Research on Women's Health, we do not have delegated funding authority, but we have the ability to co-fund. So when applications come in that are focused on women's health, this is a disease and disorder that affects women slightly more than men, or it deals with sex differences research, then we will co-fund those applications.
So wouldn't you think that the working group would be the ideal group of individuals to help develop an idea or a question before sending the grant out for review?
Well, the program announcements that are currently out were developed by the working group. So they did capture the essence of the working group's ideas about what would be the priority areas for research in ME/CFS at the time that they were written. So that was part of the working group's task, was to write those and then to send those out. But you're right, it's complex. because we have to be able to bring in the applications, assign them to an institute or center for funding possibility, and then at that point fund them. But I am always available to consult with do technical assistance consulting with anyone who's interested in submitting an application, regardless of what area it's in. And if I don't know anything about disease XYZ, I will find out.
See, this is the circular problem that CFS investigators have. Mm-hmm. There's no home to go to, mm-hmm. and you say, well, you need to make it specific to the call, but we don't have that program officer to help us say, you know what, if you tweaked it this way, it would be more attractive to have this grant. And then those grants that go in from CFS investigators, mm-hmm. MECFS investigators, are already at a disadvantage because they didn't have that kind of one-on-one assistance from a program officer. Mm-hmm. So it seems to me, again, that the working group is the perfect avenue for this. And if we could develop that mechanism within the working group, we would give the MECFS investigators the same advantage that all of the other investigators for other illnesses have.
I understand what you're saying. I hear what you're saying. I would still point out that the individuals who wrote the program announcements and who were involved in developing those to go out are the same program officers who are listed as potential contacts. So, but I acknowledge
understood.
I acknowledge that there's an issue there. Yes.
So, and thank you for the explanation. So my second question is, I'm curious as to the kind of the details of the collaborations that you're trying to. For example, the NIH Pain Consortium seems like an excellent collaborative opportunity due to the overlap between pain and fatigue and their kind of development over time. They've increased their presence. They have they've certainly become larger and are really instrumental in the roadmap initiative. So can you give us a little bit more detailed explanation on the collaborations that you're seeking with the NIH Pain Consortium?
What we're trying to do when we seek out a collaboration is to leverage resources and leverage expertise. The reason that we are interested in working with the NIH Pain Consortium is because many of the individuals serving as the IC representatives on the Pain Consortium also serve on the Trans NIH MECFS working group. So there is a significant overlap in the interest and the involvement of the individuals. As you said, the Pain Consortium is further developed. It has a lot of support financially and from stakeholders and from Congress. So there is a significant amount of interest in what they're doing and how they're moving forward, and we would like to be able to be part of that and use what techniques and methods and approaches they use to move their agenda forward and apply that to ours. And we are, I admit, we're young because I'm new, and I'm afraid I'm still trying to learn and do things at the same time, but that's what I think the working group has in mind, is to combine and collaborate with whomever's available to move things forward.
Thank you.
You're welcome.
I think Steve had a question.
One of the important things in the Affordable Care Act, if it just passed the Supreme Court. Oh, sorry. One of the important things for the Affordable Care Act, if it exists past the Supreme Court, is the appeals process for denied claims. And with health insurance claims, there's a particular problem, because if you have to hire an attorney, how do you pay the attorney? There's not typically a fund that's available. So it might want to be considering some provision for attorney's fees so that the provider can get the benefit without having to cough up some of that, and the person can get the care if it requires an attorney at some point.
Okay, thank you for that comment.
This is a question for Deborah. You mentioned that HRSA was distributing the CME. Two questions. Is it the CME collaboration with Medscape or the current CME on the website?
It's the CME that was developed with the support of the CDC that's on Medscape.
Okay, and then my follow-up is, you had mentioned, in addition to that, you provide materials to educate about CFS. Which materials are you providing?
I didn't say that. I said that the Medscape CME was distributed along with an explanation for why it was important for our grantees to take a look at it.
Oh, an explanation. Okay, but not an explanation about CFS.
It includes It includes a description that CMS. I can tell you that it says.
Okay.
It says chronic fatigue syndrome is a complex disorder characterized by overwhelming fatigue that is not improved by bed rest and that may be worsened by physical and mental activity. Because the cause or causes of CFS have not been identified and no specific diagnostic tests are available, diagnosis and management of CFS can be challenging to healthcare providers. So that's sort of that we understand. The Secretariat has asked agency leadership to commit to an action plan and develop a department-wide strategy to address chronic fatigue syndrome. HRSA has been involved in this work and has agreed to disseminate information about CFS through our various communication channels. Our sister agency, CDC, has recently launched a free continuing CME that is titled blah, 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 blah. This course is hosted by Medscape and is accredited, blah, blah, blah. And basically we invite them to take a look at it and let us know and give me feedback on basically I'll be collecting over the next few months how the distribution went, who got it, and I'll be able to provide that information to you at the next meeting.
Okay, that was a good explanation. I just wish that it would have included a little bit more verbiage about chronic fatigue syndrome because it always stops short. It was like how it was on the CDC website where it just said about fatigue. It didn't go into anything more.
Right. Well, this is an invitation to clinicians to take a look at the CME, and clinicians love CME. It's required for us to keep our licenses, and so just the fact that CME is attached to it means that people will spend that lunch hour or whatever reviewing it, getting the CME credits, and then we all win. So I understand what you're saying, but back to HRSA, what we wanted to do was get it in the hands of clinicians that are actually serving those millions of patients that we support, and make sure that they read it, that they took the course.
Okay, thank you.
Marianne?
I guess this question is for Elaine, but maybe also for several others. As an example, my laboratory has been funded by quite a bit by the NIH with the specific aim of the protocols that I submitted and were funded and did to develop biomarkers and ways to not only diagnose chronic fatigue syndrome but to follow patients under treatment by clinicians. This work has been published in peer-reviewed journals. Everything that goes out about chronic fatigue syndrome says there's no test that you can do. So what we've really sunk to is the level of Great Britain, where physicians can't order anything on patients who have chronic fatigue syndrome except behavioral modification and exercise. And I just don't know when this is going to ever change. I'm all for the primer that was put forward yesterday, but it's just like every other thing that goes out, and the one that went out from your saying that there are no tests that you can do. And at what point can we move beyond that?
I think that's a really important question, and I don't know how qualified I am to address it, but I'll say a little bit that publication in peer-reviewed journals is often a criteria for saying that something is no longer, and whether or not something is in the experimental investigational status or not. So. One approach is for when if claims are denied, for people to appeal that and to use that research and take that research to their insurance company and contest that. So that's one piece of the answer maybe. But I think having more evidence and more research obviously is the ideal.
Yeah. Well, like I presented at the NIH-sponsored workshop about immunologic markers, and that didn't seem to make any major impact. And the problem is that the insurance companies, if you put chronic fatigue syndrome, a physician puts that on the requisition for a test, that's a death knell to ever being paid for. They have to think of some other diagnostic code to put on the requisition for the test.
I just had a quick question for you, Marianne. If somebody sends out, let's say, natural killer cell function test to your lab, and they're a Medicare recipient, will they get that test covered? Unless they use the right code?
Sometimes, but
They have to use the right code.
It kind of revolves around what diagnostic code was put on the request.
Miriam and Susan, one thing that I certainly could do is go back to our agency and talk to our coverage people and get some more detail about what the Medicare coverage looks like for these kinds of tests for CFS, and just start a discussion with them about find out where that is now and just initiate a discussion.
I know there's a big push to limit the number of unnecessary tests that are done with the meritorious aim of reducing healthcare costs and the rise thereof in this country. But I don't think we're talking about things like, doing tests for prostate-specific antigen on every man over the age of 50, which is, and particularly those that are over the age of 80, it's silly. But because they will be positive probably, and can result in harm to people. But anyway.
Well, maybe if you could give me, maybe we could talk offline a little bit, and you could give me some specifics about some of the tests that would be ordered that currently are typically not covered. Then I could just look into our policies on that as a start. That would be helpful.
Just to be clear, I think part of the problem is that the evidence for biomarkers, we're still at the they're associated with chronic fatigue syndrome stage. We're not at the causative stage yet. And until we get to, if you manipulate this biomarker and CFS gets better, or this biomarker is so unique to CFS that it has to be the causative mechanism for their illness, that's what's going to be necessary, I think. I think we're still, these biomarkers are associated with chronic fatigue syndrome. There has not been any data to show that they are causative for chronic fatigue syndrome.
Well, I think that's a misinterpretation of what a biomarker is. There are biomarkers that indicate
it's one
specificity,
interpretation
and
of what
that's
a biomarker
like
is, not a misinterpretation.
To HIV, that's a definitive biomarker. But there are many other biomarkers that are used to help the clinician follow the patient and understand the state they're in, how they're responding to treatments. These are also biomarkers, and they're very important.
Well, it's not a misinterpretation. It's one interpretation of what a biomarker is.
Eileen first.
It's just quick. I agree, and I remember Nancy Klimas saying for so long, she went on record, we have biomarkers. I think what we're talking about is subsets. And until we define subsets, we'll continue to be able to deny that there are biomarkers for CFS when there really are biomarkers.
And not only biomarkers, tilt table tests and so on, or other tests that we use to help fine-tune our treatment.
For certain subgroups.
Those, to me, that's a biomarker too, if you ask me. So, yeah. Jordan.
Yeah, I just wanted to make a point that just listening to Marianne and Dean, and I think that everyone has a valid point. I think obviously there are different subsets and different types of biomarkers. So there's a disease-specific biomarker that you can only find in a specific disease and you don't find in any other diseases. And then there's a therapeutic biomarker that actually goes up with disease activity, and I think that's what you were referring to. And as the disease gets worse, the biomarker would go up, and if you actually give a treatment, it would actually go down. It's like cholesterol is one of those specific examples, and I think that we probably have different subsets of biomarkers. I'm not aware of a disease-specific biomarker in chronic fatigue syndrome or any CFS so far. And I think the bigger question that I think was at the beginning of this discussion, and the real question is how do you actually get a research biomarker to become a clinically accepted biomarker? So that as far as I know, there's like a validation process, and maybe FDA can clarify, or I think there should be a process where you can actually take a biomarker from the bench to the clinic and use that biomarker as a common tool that you can actually use.
And to Mary Ann, you know, the primer is an evolving document, and they would welcome input from your laboratory saying, listen, these are the biomarkers that we believe are useful in the clinic and that should be included to the list of tests to send out on samples. I mean, I think that they would value your lab's input on that.
We are into our next hour, and this is a question that we might want to just bring up again this afternoon. Would that be okay, or?
Sure.
I don't want to cut it off.
Sure.
Okay, good.